Welcome to Derm Clarity, Poor Decisions and Flake News. I'm Erica Ramos. I've spent over 21 years in healthcare. I'm a dermatology physician associate, doctorate of medical science, the founder of RestoraScalp, and the host of this podcast. I'm here to help you make sense of your skin without the hype. Just a quick note before we dive in. This podcast is for education only. It's not medical advice, and it doesn't replace the care you receive from your own provider. My goal is simple: to help you understand what's happening with your skin, hair, and nails, so you can make informed, confident decisions alongside your care team. Welcome back to Derm Clarity. Today we're talking about something that confuses patients and honestly sometimes confuses providers. When your skin and your joints are actually playing the same game. Spoiler alert, the immune system doesn't care what specialty you booked your appointment in. Today, I'm so excited to introduce Dr. Jennifer Apodaca. She's a PhD, PAC. So she has her PhD in molecular medicine. She's a PA and has worked in primary care and rheumatology. And she's been in pharma or medical affairs as a medical science liaison in rheumatology and dermatology for the last several years. Today, we're going to be breaking down the rheumatology-dermatology overlap in a way that actually makes sense. If you've ever thought, why do I have a rash and joint pain? This episode is for you. Okay, let's start with the biggest misconception. Skin issues are not always just skin deep.
So true. Yeah. So a lot of skin conditions are actually driven by our immune system, right? But that same immune system can affect our joints and some of our organs. You can think about things that, can attack our gut, can attack our joints, can attack our eyes, heart, lungs. Really, any organ is fair game for the immune system.
Yeah. Sometimes it just wakes up and chooses chaos, and patients feel that. They come in for a rash, but they mention, God, I'm so tired, or my joints are so stiff in the morning and I can't move them. My joints are locking up or they're swollen.
Yeah. And I mean, those are the moments where you just have to be like, look, this isn't just your skin that your immune system is attacking.
But the hard part is patients often get bounced around and they end up taking a while to actually discover what's going on. They'll come to dermatology to see me, rheumatology to see you when you were in practice, primary care. And, it's really hard sometimes to connect the dots, even when you're the person in the provider chair with your patient. Like I'm sitting there staring at a rash, and sometimes I have to use my biopsy to actually figure it out.
Yeah, and I mean, same thing whenever they come in to see us, and they might tell us about a rash, but they're also telling us about their joints, or they might go to the GI doctor and complaining about all these loose bowels, but they also, notice some psoriasis on them. And all these things just interplay with each other because there's the joint gut axis, there's all the whole microbiome that gets involved. And yeah, there's just, it's all interplaying and working together.
I feel like there's patients on both sides of the spectrum where you have that patient that comes in and they're like, I think all this is connected, right? And sometimes you're like, no, it's not connected. But then there's also the patient that's like, well, I didn't want to mention it because it couldn't possibly be connected. And then you're
Yeah.
like, why didn't you tell me that? This is very valid. We needed to know this.
In primary care, one of the doctors I worked with, he had this really like awesome saying that I would tell patients all the time. I'm like, sometimes you just got fleas and ticks at the same time, and we have to treat them separately. But sometimes those things are connected, and we can choose one thing and treat all of them.
I like it. I say oranges and apples.
Yeah.
You're just a fruit salad today.
Yes. Yes.
Okay, so let's hop into one of the major overlaps that I think is super common in derm and rheumatology is psoriasis and psoriatic arthritis. It's a classic combo. Sometimes the skin plaque shows up first, but not always. In general, they're these thick, silvery plaques, and they're really common in areas of friction like your elbows, your knees, your scalp. How about from a rheum perspective?
And we know that up to 1% of the patient population has psoriasis. And of those, a certain percentage of them will go on to develop psoriatic arthritis. And from a joint perspective, we say joint, but really it's soft tissue as well, right? Because it can affect just a couple of joints in the hands, but it could also affect like those attachment sites, and you can get like enthesitis, especially like the Achilles, that's a common place. So we're thinking, yeah, joints, but we're also concerned about, some of those attachment sites too, because it really affects those things equally.
Yeah, that plantar fasciitis, that feel like you're walking on pebbles kind of sensation, all of that could be inflammation in the joints. And then there's the findings on the x-rays, which are pretty characteristic of whatever rheumatic disease you're looking at, right?
Yeah, yes. So when in RA, we think of more a symmetrical disease. So we're thinking about like the knuckles or the MTPs. But when you think about psoriatic arthritis, you're thinking of those middle joints in the fingers, these PIPs.
Mhm.
And when you look at it on X-ray, you're more likely to see like frank erosions, with RA, but with PSA, you can see erosions and hypertrophy. So with psoriatic arthritis, your bone wants to correct itself. So it starts laying all this extra bone, and you can get heel spurs or, just these kind of hooky looking things on X-ray that where you don't see that too much in RA.
Yeah, when I was in the rheumatology fellowship, they would say it was like cotton wisps, like you were just like you would pull cotton and that's what you can see kind of coming off of those attachments of the tendons and erosions kind of around those areas sometimes.
Yeah, and calcifications in the ligaments too. You can see that on X-ray as well, and that just tells you, okay, this has been going on a long time when
Yeah,
you're
so
seeing,
if you're a
calcification.
rheumatologist or even your dermatologist, maybe if they're kind of room savvy, if they're telling you, "Hey, I need to get X-rays," it's because they're looking for those classic signs of psoriatic arthritis. If you're complaining that your joints on top of your skin tearing and having that plaque everywhere.
Yeah, so
Also,
true.
nails. Psoriasis can
Yes.
affect so many things, right? We know even beyond the joints and the skin, we know it's an inflammatory process throughout the body as well. So we've got that increased risk for heart attacks, strokes, but we'll see it in our nails. And sometimes it looks like it had a tiny hailstorm and you've got these little
Yeah.
woodpecker dots all over your fingernails, or it can thicken up and it can kind of look like you have a fungal infection on your nail, but it's not fungal. Or sometimes these spots that even look like there's oil droplets under your nails. So, all kinds of findings that could be cues that maybe you're dealing with psoriasis and maybe at a higher risk for psoriatic arthritis as well.
Yes, and you brought up such a good point about those patients having a higher risk for cardiometabolic issues, high cholesterol. They're typically overweight, and so you see a lot of metabolic syndrome that goes along with psoriasis and psoriatic arthritis patients.
Another thing I just thought of when you said that was that it's incredible how much smoking can affect your psoriasis and your inflammatory disorders. So if you're thinking of ways that you could reduce your inflammatory load and you're a smoker, you should really, really, really try to stop smoking as well.
100%. Yes, for sure.
And then I think it was our first podcast, we had a PA on who was talking more about dietary changes and using more of a holistic approach as well. And so we also used to recommend Dr. Will's anti-inflammatory diet. Do you
Yeah,
remember doing
yes.
that before?
Yeah, I do remember that. And then also, yeah, because there's like the gut joint, gut skin axis, right? We know that a lot of these things are sometimes the catalyst is being driven by just a unbalanced flora in the gut, and there's just more science and more research coming out in terms of how all that's connected, especially in autoimmune disorders.
Yeah, I think there's been a lot of discussions about the gut axis at the conferences lately.
Yeah, yeah. There's a lot of work being done, so it's good work.
Yeah. Another thing that we'll see crossover from rheum to derm is lupus. This one's tricky because you can just have skin lupus. Just like you can just have skin psoriasis, you can just have skin lupus, but there's also systemic lupus. What kind of things are we looking out for when it comes to systemic lupus?
Yeah, more like along those lines of like an inflammatory arthritis. So there's going to be joint pain, morning stiffness, all those things that you would think of. There's a lot of fatigue with lupus, and there can be some soft tissue, like myalgias too, that go along with it. So a lot of times it's hard to figure out, do they have fibromyalgia with overlapping lupus, or is this their lupus causing some of their, myalgia and fatigue? So it gets tricky. Lupus also can affect any organ, right? Kidneys are a common one that we hear of, but it could also affect like the pericardium of the heart, the pleura of the lungs, so and definitely the skin, right? right? That's another huge organ that it can impact. So lupus should be a great mimicker of a lot of things, but it could also be your lupus.
It also can have multiple different presentations in the skin as well. So you can just have the malar rash. Some people are just really photosensitive. It's like they're almost allergic to the sun and they'll break out in a rash with that. There's discoid or these little round lesions that can scar.
Yeah.
And a lot of times, if it's just skin only lupus, you're going to hear your dermatologist tell you that number one thing is going to be protecting yourself from the sun, wearing photoprotective clothing, making sure you're wearing your sunscreen. And I think, that would still be the same recommendation from a skin perspective in somebody that had systemic lupus as well. Let's talk about dermatomyositis.
Yeah,
This one
nasty.
also, I keep saying this one can just be skin, or one can also have a muscle involvement or a systemic kind of involvement as well. So, Jen, let us know how does this affect your muscles?
Yeah, you're going to see a lot of weakness, especially those proximal muscle weaknesses. You might see if it's suspected, they might get labs. You may see some LFT elevations. You're definitely going to see, some muscle enzyme, either aldolase or CK elevations, markers of inflammation. You might see elevated. So especially if there's a skin and they get referred over to a rheumatologist, they're going to run all these labs, but you likely will too, if you see them with those kind of classic signs of just the rash, then you might prompt them from a question and answer type of thing. Do you have any weakness? And you might be able to elucidate what's going on there. But
Yep.
also, we worry about malignancies with these patients too, so we oftentimes in rheumatology, we do like a chest, abdomen, and pelvis CT just to look for some solid organ malignancy because there is a relationship there.
Mhm. Yeah, from a skin perspective, sometimes they call it amyopathic dermatomyositis, meaning there's no muscle involvement, it's just skin. And so sometimes we'll just see kind of what they call a heliotrope trope rash on the eyelids, but it's kind of purple or violaceous on the eyelids. And these Gotrin papules, which are on the knuckles, they're just like little bumpy lesions on the knuckles. Sometimes they'll have rash around the chest, shoulders, and upper back. And they'll also have dilated vessels around the nails. And, funny thing is that I was at work today and I worked with one of the physicians and he just showed me pictures of this exact thing this morning. So, it's not something that comes in a lot, but when you do see these signs, or if you see the rash on your eyelids and the rash on your knuckles, your provider's probably gonna be also asking you about your muscles in the dermatology clinic or asking you about being able to pick up a jug of milk.
Yeah. Yep, exactly. And being able to stand up without hoisting yourself, with your arms,
Oh,
something that we would
I
ask
might
a lot
even make
too.
you squat, like, I might make you get out of the chair, without using your hands just so I
Yeah.
can see it.
Yes, I would always say, "Cross your arms and stand up."
So, then there's something else, that also might have some of those little dilated capillaries around the fingertips. We might see that in something called scleroderma, which can be a systemic issue. There's also gonna be some potential for having limited versions of that just on the skin as well, but the systemic one's the really big and bad one and definitely something that you don't wanna have to live with. So do you wanna run through some of the systemic stuff with scleroderma?
Yeah. So a lot of the times they are going to present with esophageal dysmotility. And that's just basically saying like they're having trouble swallowing or they have excessive reflux or GERD. They can also have some vascular changes like those telangiectasias that you can see around the mouth. They can have memory nodes, which is just basically, the whitening of a digit whenever it gets cold, or even sometimes a whole hand, can
Mhm.
become white with cold,
Yeah,
joint
that's if you
stiffness.
go to the freezer section of the grocery store,
Yeah.
your hands are turning, like,
Yeah.
blue.
They'll turn white, so that, yeah, those things. And then they can also get joint stiffness too, no matter what probably autoimmune condition we're talking about, there's joint pain that's usually going to be associated with that. And this is no different. They can
Mm,
also have some of those, joint pains too.
yeah. It's worth mentioning a lot of this inflammatory arthritis is because we all get osteoarthritis, right? We all get that old age arthritis, and
Yes.
none of us can avoid it. But that kind of arthritis is usually end of day, you've been busy, you've been on your feet all day, and man, my joints are just mad at me because I've been busy all day. Whereas the inflammatory type, do you find it's more in the morning and stiffer and or maybe throughout
Yes.
the entire day and it has nothing to do with how busy you were that day?
Yeah, and so it can really depend on the condition sometimes, right? Like AS, like you can get night inflammatory back pain or like an early morning, and then a psoriatic arthritis, rheumatoid arthritis, there's a morning stiffness, and we usually say, does it last longer than an hour? Because that's not typical. Because osteoarthritis, you can usually work yourself out. You get yourself all oiled up, and you're good to go at about an hour, or maybe even less. But these inflammatory arthritises, yeah, they can persist longer than an hour. They can, come back if you've been seated for a little bit and then you get up again and you just feel kind of stiff again and it takes you about a long time to loosen up.
Mhm. You just briefly mentioned, like, rheumatoid arthritis, and you wouldn't maybe think that there's actually skin involvement in rheumatoid arthritis, but sometimes we can have these little nodules, sometimes around, like, our elbow, but what's going on underneath the surface with this one?
Yes. Rheumatoid arthritis is a symmetrical inflammatory arthritis of the small to medium joints. So you think knuckles, we think wrists, sometimes the elbows, rarely shoulders, but it can happen. Rarely hips, but it can happen. Rarely the knees, but it can. We always say rarely because you can never say never with any sort of inflammatory
Right.
condition. But you're going to think of like the toes and kind of the knuckles of the toes or those MTPs where you see a lot of it starting, and it's going to be swelling, stiffness, pain in those areas, a lot of morning stiffness, fatigue. There can be other involvement of like the heart can be involved with rheumatoid arthritis. The eyes, people can get inflammatory conditions of the eyes that can be associated with RA as well. And then, of course, the lungs. That's a big one, that we worry about with our.
Yeah, and you don't think of that as much. You'd think of just joints when you think of rheumatoid
Yep.
arthritis. There is another crossover condition called Sjogren's, and from a skin perspective, we're going to see this as really, really dry skin. They're just going to be complaining of being dry all the time. From a more systemic perspective, you'll see dryness in other places, right?
Yes, dry eyes, dry mouth, constantly complaining of that dryness because it is very, very intrusive in terms of how dry people can get. And we think, we're like, oh yeah, I've had dry mouth before, but this is just like dry mouth to something that probably you and I can't even imagine, right? Same thing with the eyes. They're going to feel just gritty, like there's sand in there. It's bad. They can also have lung involvement too. There can be that's a little bit more rare but they can have it. There can be joint pain with that as well. And then we worry about excessive dental cavities with them.
Yeah.
Oftentimes we would tell them try and go get your teeth cleaned every 3 months because that dryness in their mouth leads to, extra cavities.
Yeah, and they make these things called siligogs for translation to normal people is like licky chewies, things that you're just gonna have in your mouth, like gum, sugar-free candies, just to try to like continue to promote saliva in these people so that they don't have their mouths so dry all the time.
Yeah, things with xylitol. Xylitol is really good about helping with dryness in the mouth for sure. And you can find that in gum or a lot of mouthwashes.
The other thing is and you talked about increased risk for cancers in a different setting, but sometimes people can have cancer with associated with this one as well in the parotid gland, right?
Yeah, yes, that can happen on occasion
Remember?
as well too. Yeah.
So, and sometimes this is actually really hard. A lot of these are hard to diagnose, which we mentioned, but a lot of them do have labs that can be positive, but then
Yep.
the labs can also be negative and you can still have it. And sometimes it requires a salivary gland biopsy to get this one diagnosed.
Oh, you brought up another good point too. There's primary Sjogren's and secondary Sjogren's, right? Things like RA and lupus, you could develop just dry mouth because of the inflammatory condition, but it's not necessarily primary Sjogren's. We call it, like secondary Sjogren's or just secondary to their autoimmune condition.
Yeah, so many things, so much overlap.
So many, I know.
When I worked at the military medical facility, it was nice because at the time, rheumatology and dermatology were positioned right next to each other. We just
Um,
door we had to walk through. I don't know that I actually said this at the beginning of this, but I also did rheumatology, and Jennifer and I worked together in rheumatology
yeah.
while. But so at the time I was in rheumatology and I would cross through that door so many times during the week to go ask a derm question because there is so much overlap in these two specialties. And one of the reasons that it's just nice for me to have the room background in the dermatology setting as well.
Totally. That would be so nice. Yeah. Or that would have been so nice to have like a dermatologist to just have a curb consultation whenever I needed it.
Next door, like, hey, what do you think about this rash?
Yeah.
And now you're doing it from a medical science liaison. You went from rheumatology into dermatology. We're both
Yes.
flip flopping around the same.
Crossing over.
Yes. Yeah. All right. This is where things get really interesting because dermatology and
Yeah.
rheumatology, like we said, kind of run parallel to one another. And so a lot of the medications also cross over into from rheum into derm and help with both aspects of these disease processes. So they're targeting the immune system itself, which is why it makes sense that it would treat a rash and a joint pain because it's really treating the root cause of that inflammation, right?
Yes, exactly. So when you think of psoriatic arthritis or psoriasis, pretty much there's not a drug that would be indicated for one and not the other. Now, one might get it before the other, but you can assume and know that within a year or two, you're going to get the other one that's going to get, the indication as well. And there's a whole host. Do you want to dive into like the different categories or classes, or what do
Yeah,
you think?
let's do it. We have a few more
Yeah.
minutes left.
Okay. So for like psoriatic arthritis, we have the IL-17s. TNF inhibitors are still used a lot for psoriatic arthritis. I know in the dermatology space, you don't guys don't use it too much for
We really
psoriasis.
don't use a whole lot of like TNFs have kind of almost walked away from the playing field in derm. But yeah, we use a lot of more of the IL-17s, IL-23s a lot.
Yes. Yep. Exactly. So those are sort of the classes that we have to look to or pull from whenever we're
Yeah, and
treating
for
this.
those of you listening that's like, "I have no idea what any of that is," those are injectable medications. There's a ton of commercials on the TV about all of these medications, so you may know all the brand names, but they're all great. These injectable medications are wonderful. They're game changers for people with these disorders.
Yes. And I will say too, I'm a patient myself. I have psoriatic arthritis and psoriasis. So I'm on an IL-23 inhibitor. I think it works great.
Now the other, like, disease modifying medications or what we used to call DMARDs when I was in the room aspect of things, I think a lot of those still run in rheumatology. I still get patients from rheumatology who are on methotrexate, cyclosporin,
Yeah.
Celsep. We don't use a ton of those medications in dermatology, but they do get used here and there.
Yes, for sure. Rheumatology, they love their methotrexate, so you're going to still see patients on methotrexate and it's efficacious, Some people that's all they need, right? So, um
And within that space, though, there's been a lot of growth of all these diseases. There's newer oral medications that are coming out. There's so many great ways to treat all of these things. You don't want anybody sitting at home thinking that they're in despair and that nothing's ever going to work because there are some just incredible medications out there that can help treat these disorders now.
Yeah, and it's really not recommended to cycle through because we know, like for IL-17s, there's several in the space, but in the rheumatology space, it's not recommended to go. If you tried one, to try a second one, they usually try and switch classes. So at some point, you are going to get to the end of the line. Treatments aren't infinite, even though there's a lot of research and there's new ones coming out all the time. This is a lifelong condition, right? All these are lifelong conditions. So it's within the realm of possibility that you're going to reach the end of the line for therapies that are available.
Hopefully, you're the person that gets the one that just clicks. And there's
Yes,
also, what we didn't mention is you in rheumatology actually use these labs a little bit more frequently than they're used in derm as well, which will tell you what biologic a patient's likely to respond to best.
that's true. Yeah, that there was, especially a few years ago, there was a big pickup of that. I don't know if it's fallen out of favor too much now. I quit asking about that, but maybe. I won't say the name of the test just to be fair, but I think that maybe there's some issues with it. So we're just quite not there yet in terms of trying to figure out, okay, this person would respond better to an IL-17 versus an IL-23 inhibitor. We want to be there though. And I
Mhm.
think eventually we will get there.
Yeah. I'm impressed every single day. I feel like just when you think we've know everything about a disease process or we've possibly hit the last medication that could be made to help it, somehow science develops more. And I just think it's incredible to watch that we just continue to learn and continue to grow and continue to make more progress with all of these treatments.
Yes, the immune system is so redundant, or there's a lot of redundancy in the immune system. So when we think about these pathways, we think of them more as like A happens, B happens, C happens. It's not really that way, right? There's this multitude of cytokines, and to your point, we learn more about this every year. With that comes new targets, right? And then you just have to figure out, is the target druggable? Meaning, can we, make
Mm,
something that can be used to fix it and then, get patients to
yeah.
feeling better
Have
because
the
that's the end
efficacy we
goal.
need and also be safe enough to use as a
Yes,
medication without a bunch of
exactly.
side effects.
Yep.
All right. Well, I think the big thing, I guess, which comes across when we're talking about these is that there is a need for collaboration between dermatology and rheumatology so that these patients don't get bounced around like pinball machines. So I think when there's difficult to treat disease or hard to figure out conditions or you're not responding the traditional medications, it's great for you as a patient or for us as providers to think, okay, I need to reach out to my colleague in room and see what else we can put together, what we can brainstorm, how we can connect the dots so that we can actually take care of the person suffering from the disease.
100%. It's so necessary. And a lot of the times, like I mentioned, you guys will have access to medications before we do. Or I can remember one time when I had a psoriatic arthritis patient. He was on one medication and I switched him. He's on a TNF inhibitor. I switched him to an IL-17 inhibitor and he developed IBD. And we know that can be, I don't want to say it's a side effect of the IL-17. It's likely that this patient had IBD, but he was being treated with the TNF inhibitor. And then I switched because his symptoms were not getting better or had relapsed a little bit. And then it unmasked his IBD. So it's nice to have that, one either GI or dermatologist that you can call and say, "Hey, help me." And they were able to get him in and we got everything sorted, but it happens.
Yeah, good for us to have that connection with one another. Well, was there anything that we didn't mention?
I think
Okay.
this is great.
Thanks for being here with me on Derm Clarity. Remember that our skin reflects our internal health. Skin often gives us early clues to systemic disease, and persistent symptoms often need deeper evaluation. Jennifer, thank you so much for being on Derm Clarity with me today. You've been such a longtime friend, and I'm so excited to just be able to be here on camera with you and talk about things that we're passionate about, rheumatology and dermatology.
Absolutely. All we were missing was a drink, but that's okay.
Right, I almost poured one right before we started. Thanks so much for spending time with me today on Derm Clarity, Poor Decisions, and Flake News. My goal is simple to help you understand your skin so that you can make more confident, informed decisions. Because at the end of the day, better skin starts with better understanding. And here on Derm Clarity, we're all about making better, poor decisions without the flake news. When you understand your skin and stop guessing, that's when clarity begins. Because great skin isn't just about what you put on it, it's also about what's happening underneath. Thanks for hanging out with me on Derm Clarity, Poor Decisions, and Flake News. I'll see you next time.